Good evening, everyone. On the behalf of IIP Raigad, I welcome today's speaker, Dr. Akanksha Chadda ma'am, Dr. Chandni Kharat ma'am, our Maha-IIP President, Dr. Gangulia sir, respected Mohite sir, our IIP President, Dr. Pramod Wankhede sir, Vice President, Dr. Vikas More, Secretary, Dr. Dhananjay Rajput sir, and respected senior colleagues and dear friends, a very warm welcome to all. Today, we are celebrating Women's Day in a very unique way by discussing on unique topics like approach to acne in children and management of skin issues due to PCOS in adolescent girls by unique speaker with unique subject like skin and gynec. Under able guidance of our President, respected Dr. Pramod Wankhede sir. I request Dr. Wankhede sir to give opening remarks. Over to you, sir.
Thank you, Sanjini ma'am. Respected seniors, my IP President, Dr. Gangulia sir, Senior Pediatrician, Dr. Mohite sir, and all my dear friends. First of all, let me congratulate our respected ladies expert rather, and all ladies members of IIP Raigad family on the occasion of this Women's Day. Dear friends, this is our second subspecialty chapter, a chapter lecture on dermatology. In next month, it will be on pediatric cardiology. As you know, Corona is declining now, and schools and colleges are open. Students are coming out to outdoor activities also, and so as their problems also. So, as you know, the students are coming out and their problems are coming out. We get to know about their problems. And skin is the most delicate and most sensitive part, particularly in adolescence. Acne are very much bothering and of great concern to the adolescent age. And so they are bothered about their this acne and other skin problems which are related with PCOD, particularly in girl child. How to approach it, when, what, all our queries will get solved with we have got two eminent personalities, Dr. Mrs. Akanksha Chadda, she is a dermatologist from Nair Hospital, and Dr. Chandni Kharat ma'am, she is a constructive gynecologist. So both will solve our all queries, make the subject simplified for us. Let us listen to them without wasting much time. Thank you very much.
Thank you, sir. I welcome Dr. Dabadkar, sir, who is senior pediatrician. Welcome, sir.
Thank you so much.
May I request Dr. Vikas More to introduce today's speaker and moderate today's session. Over to you, sir.
Thank you so much, Sanjini ma'am. And on the behalf of IIP Raigad, I am Dr. Vikas More. Today, I know that in my VCOPD, when I see that the adolescent girls or boys, when they come to me with the problems like acne, which are often ignored by parents and they take it very casually, but we understand that acne is not only a physical issue, it is also an emotional issue, because during adolescent age, everybody wants to look good, everybody want to make impress upon. So they can't express themselves, and as a pediatrician, we actually are the first people to whom they share their agony, but most of them are not properly cured. Today we are having a very eminent speaker, Dr. Akanksha Chadda, who is a graduate from Grand Medical College and postgraduate from St. G.S. Medical College. Right now she is working as an assistant professor in Propionic Medical College. She has various publications on her name, and she also organized various conferences. And on her extracurricular part, she has also worked as a child artist in a Hindi serial, that is Bachcho Ki Adalat. So she is a very multifaceted personality. I am so happy that she came today, and today is International Women's Day, and we are having a eminent women speaker who will guide us on this wonderful and important topic. Over to you, ma'am.
Thank you so much, Dr. Vikas, for such a nice introduction. Shall I begin with my presentation? I'll share my screen.
Yes, ma'am, you can go ahead.
Okay, so today I will be talking about acne and the basic management that can be done by pediatricians. Now, what exactly is acne? It is a chronic inflammatory disease of the pilosebaceous unit, and these units on the face, because the facial hair is villous, the opening is not that big for those the secretions to come out, and that is why acne is formed. Now they are characterized by seborrhea, formation of comedones, erythematous papules. Papules are small erythematous less than 1 centimeter lesions. They can be filled with pus, and less frequently there can be nodules, there can be cysts, and later these might lead to scarring. And that is why the treatment of acne is important. Now, usually these lesions, they start around adolescence. They can present in neonate also. They can present beyond adolescence in susceptible individuals. Physiological acne is considered a normal variant of maturation. It is not a disease. It is a disorder which can be seen in people who are prone to acne. Clinical acne persists and progresses beyond the period of adolescence, and almost 30% of teenagers have acne of sufficient severity to require some form of treatment. Now, what is happening in acne? There are 4 main pathogenic causes. There is hypercornification of the pilosebaceous duct. Now, what is happening is the keratin formation is plugging the opening of the pilosebaceous duct. That is hypercornification. There is increased sebum production, and later on, when the sebum production increases and a small comedone is formed, there is colonization of the duct with Bacterium acne, and later this causes inflammation. Now, this is a diagrammatic representation. This is a villous hair. This is the sebaceous gland, and it opens inside the hair follicle. Now, what is happening is there is keratinase plugging of this opening, after which there is increased sebum production, which kind of collects, and then later this collection there is increase in the colonization by Bacterium acne. As such, the bacteria is not the primary cause. The primary cause over here is because of the hypercornification of the pilosebaceous unit that is occurring at this age. Now, what exactly do we mean by seborrhea? There is an increased androgenic sex hormones of gonadal or adrenal origin, especially in women with polycystic ovarian disease. Now, these hormones, along with abnormal end organ response to normal level of hormones, cause an abnormal composition of the sebum. There are lower levels of linoleic acid, and this leads to ductal hypercornification. Comedogenesis, when there is abnormalities in the proliferation and differentiation of the ductal keratinocytes, there is retention of the hyperproliferating ductal keratinocytes, and there is increased cohesiveness of these keratinocytes. All this will lead to the formation of microcomedone, which is a precursor in all these acne lesions. About Propionic Bacterium acne, it is a normal resident anaerobe which colonizes the pilosebaceous duct in the presence of seborrhea. Now, what this bacteria does, it hydrolyzes the triglycerides in the serum to produce free fatty acids, which cause inflammation. These produce mediators of inflammation, and the cell wall of T. acne is a potent chemoattractant, causing increase in neutrophil and macrophage migration at the site of the occlusion. All of this will lead to inflammation. There are cytokines produced by the sebum and ductal keratinocytes. The Propionic Bacterium acne and the free fatty acids also will contribute to the inflammation. The cytokines that are produced will attract neutrophils and mononuclear cells. And in moderate to severe cases, there is rupture of the duct, and the macrophage giant cell foreign body reaction can occur. Now, pediatric acne, they can be classified into 4 main types. The one occurring in neonates, which is called neonatal cephalic pustulosis. Then there is infantile acne, childhood acne, and pre-adolescent acne or adolescent acne. The pathology behind pre-adolescent and adolescent acne is the same. Okay, now coming to neonatal cephalic pustulosis. In this, there will be neonates who present with multiple pustules, mainly on the forehead, cheeks, and chin. Less commonly, it will be seen in the trunk. Now, here the problem is not. This is not true acne. What is happening is there is increased inflammation because of increased colonization of Malassezia furfur, and it is not because of the acne pathogenesis that I have explained. So the treatment for this are antifungals and not antibacterial or anti-inflammatory agents, which I will be coming to. The pathogenesis of this condition is completely different. Infantile acne, this is usually seen between 3 months to 1 year of age. This is because of the maternal estrogens and progesterones, which have an effect on the neonatal pilosebaceous unit. And this has to be treated like acne. And usually these patients, they are more prone to develop acne in future also, in the adolescent age group. Childhood acne is a very rare condition. It is not usually seen between 1 to say 8 years of age. If a child at this age is developing acne, you have to evaluate him for underlying hormonal imbalance. Now, what evaluation is required in these patients? The LHSS levels, free testosterone levels, the dihydroepiandrosterone levels, 17-hydroxyprogesterone levels, prolactin may not be required, and X-ray hands for bone age. Now, this is done because in infants, we do not usually have adrenal or any gonadal androgen secretion. So there are various conditions of the adrenal or gonadal origin which can cause these acne and need to be evaluated, and hence this, like congenital adrenal hyperplasia will present with childhood acne, and the DHEAS and 17-hydroxyprogesterone levels will be raised. Now, young girls who are prone to develop PCOD or anyone who's having ovarian tumors, in those, free testosterone levels will be elevated with a normal DHEAS and 17-hydroxyprogesterone level. Hence, childhood acne is not a normal condition and has to be investigated in detail. I will be coming to pre-adolescent and adolescent acne after this slide. Now, what are the grades of acne? There are, for management purpose, it has been classified into 4 grades. In the first grade, there are predominantly comedones. And the second grade, there will be predominant papules. Comedones and few pustules can be present, but papules will be the predominant lesion. In the third grade, there will be predominant pustules. Nodules or abscesses can be seen, but it is mainly a pustular variant of acne. And in the fourth grade, you will see nodules, abscesses, cysts, and scars. Now, this classification also is mainly for adolescent and pre-adolescent acne. You don't see this in infantile acne or neonatal acne or childhood acne for that matter. Now, these lesions are classical comedonal lesions. A few papules and pustules are also visible. So, this will be classified into grade 1 of acne. Here, we can see papules and pustules and comedones in between. So, this will come in grade 3 of acne. Here, we can see multiple nodules and a few cyst formation is occurring on the chin. So, this is grade 4 acne. This again, here there's a cyst formation, multiple nodules are seen, interconnecting bridges are also seen. This is nodular cystic or grade 4 acne. Now, the issue with acne is that they are usually just visitors in this age, but they cause scarring, and this is a consequence of abnormal resolution of the wound healing following the inflammation. Ice pick scars are seen in most patients with grade 1 and 2 acne, while depressed or hypertrophic scars are seen in nodular cystic acne. Hyperpigmentation can be seen particularly in type 3 and 4 skin, which is Indian skin. These hyperpigmented macules may persist following the resolution of these inflammatory acne lesions. Now, this is the post-inflammatory hyperpigmentation that has occurred in a patient. And if you can see over here, there are few scars also. Now, this is a patient of grade 4 acne. Usually, these patients heal with hypertrophic scar. If you see at the mandibular level here, there is a lot of scarring that has occurred. This is a patient of frontal acne. The acne has settled to a large extent, but the scars remain. And this causes a lot of psychological trauma to the patient. This is post-inflammatory hyperpigmentation following the acne lesion. These are primary comedonal lesions. If you can see, comedones can be open or closed. These lesions are closed comedones, but if you can see an opening of the hair follicle and a punctum, these are open comedones. Here again is a picture of comedonal acne. Now, acne can also be drug-induced. In drug-induced acne, papules and pustules are usually present and comedones are absent. The common drugs that are implicated in drug-induced acne are halogens, androgenic compounds, steroids, isoniazid and rifampicin, lithium, phenytoin, and UVA therapy. Now, why treat acne? And its psychosocial aspect. Now, stress can induce acne, increase anger and anxiety. Acne can cause social embarrassment. There is lack of self-confidence amongst the adolescents. It can cause depression and also dysmorphophobia. Now, this is a case of drug-induced acne. If you look closely, they are mostly papules and few pustules, but comedones will not be seen. Coming to the treatment, acne assessment is very important, and also classification into the various grades is important because the treatment will differ depending on the grade of acne. You have to educate the patient about the need of treatment, and also most of these patients, because it causes psychological trauma, they have a habit of picking on the acne lesion. And when they do that, it causes scarring and it has to be avoided. You have to discuss the goals of the treatment and the expectations of the patient and the choice of therapy. Again, the choice of therapy, like I said, will depend on the grade of acne. Now, treatment. Now, topical antibiotics, the ones that are mentioned, they are not used because of their antibiotic action, but for their anti-inflammatory action. So, topical erythromycin, pardon the spelling mistake, clindamycin, topical tetracycline, clarithromycin, and doxycycline orally is given. Now, these macrolides are doxycycline, tetracyclines, these are used for their anti-inflammatory action. Topical benzoyl peroxide is used for its anti-inflammatory and antiseptic action. Acetalic acid has a comedolytic effect too. And topical retinoids, like retinoic acid and adapalene. Tazolotine is not used so often, but we should stick to retinoic acid and adapalene. Now, most of the acne lesions can be treated with a plus minus of these 4 agents itself. Mild grade acne, grade 1 and grade 2 can easily be managed with this in various combinations. Orally, we can use erythromycin, azithromycin, although there is a lot of resistance that has developed to azithromycin. Tetracyclines like doxycycline and minocycline can be used. Trimethoprim and dapsone can also be used for acne if required orally. Now, these antibiotics have to be, when they're given an anti-inflammatory, for their anti-inflammatory action, they have to be given for longer period of time. Hence, these side effects also come into the picture. Doxycycline can cause onycholysis. It can cause esophagitis with ulceration. It can cause fixed drug eruption and can also cause photosensitivity. Minocycline can cause benign intracranial hypertension. Even doxycycline can cause benign intracranial hypertension. Hence, they have to be used carefully. They have to be avoided in patients who have epilepsy or any history of seizures. They can cause papilledema. Minocycline per se causes blue-black pigmentation and some hypersensitivity reaction. That is why it is not used very commonly, even though it works excellent. Then the macrolide group can cause gastritis and diarrhea. Cotrimoxazole can cause severe drug reaction. Dapsone can cause hemolytic anemia and dapsone hypersensitivity syndrome. Hence, whenever required, they have to be used with caution. Now, isotretinoin is a vitamin A derivative. It is chemically 13-cis-retinoic acid. Now, what is the mechanism of action? Isotretinoin will decrease the size of the sebaceous gland. It causes 80% reduction in the sebum. It alters the composition of sebum, which causes hypercornification. It reduces the comedonogenesis and it lowers Propionibacterium acne concentration and also has anti-inflammatory action. Now, when should isotretinoin be used? In grade 3 and 4, like nodular cystic acne, pyoderma faciale, when the patient comes with a complete red face and is having even systemic symptoms, then the acne that is reclassified for routine treatment. If the patient is having excessive sebum production, if the patient is depressed because of the acne or has dysmorphophobia, acne conglomata or other unusual variants, the cystic acne with bridging lesions that I showed you, the acne conglomata, and if the patient is having scarring. Now, when patients in the adolescent age present to you, they may not come with scarring, but if they have large nodular lesions, later on, they will scar. Hence, it is better to treat them at the earliest so that the patient is not left with that scar, which is very difficult to manage later. Now, what is the dose of isotretinoin? Around 0.5 to 1 mg per kg per day is given, but usually 0.2 to 0.3 is enough. Cumulative dose of 120 to 150 milligram per kg is to be reached, but around 80 mg per kg is also enough. Now, what are the side effects? It is teratogenic. It is not to be given to pregnant women who are planning pregnancy and to pregnant women. It has mucocutaneous side effects. Dryness of skin, dryness of the conjunctiva is very common. Then it can cause hypertriglyceridemia. Then, because of increasing the intracranial pressure, it can cause pseudotumor cerebri, optic neuritis, depression, and mood swings. It can cause arthritis and myalgia, and it can also cause flare of acne. Initially, when isotretinoin is given in severe nodular cystic acne, it can cause acne flares. Hence, it is important that we first treat with topical medications, get the acne slightly under control, even when it is severe with scarring, and then later on give isotretinoin so that the new acne stop erupting and the scarring is prevented. Now, the treatment plan. So, initially, we have to start with topical therapy for grade 1 and grade 2 acne. Oral antibiotics for their anti-inflammatory effects, they are to be given in moderate to severe acne. Combination with topical retinoids improves the efficacy, and with benzoyl peroxide decreases the resistance. Now, whenever we are giving topical clindamycin, also clindamycin has an anti-inflammatory antibiotic effect, but resistance can develop. Hence, topical retinoids and benzoyl peroxide should always be added to the acne regimen. Now, duration of treatment has to be explained to the patient that he has to use the topicals at least for 4 to 6 months, even if the acne stops erupting. Any new treatment that is started must be continued for at least 6 weeks before changing. The patient has to be spoken in detail about the potential side effects. Systemic isotretinoin is indicated in severe nodulocystic acne, acne conglobata, and acne recalcitrant through routine therapy. It is not indicated for grade 1 and grade 2 acne, hence it should not be overused also. Now, what are the reasons for poor response to therapy? Most of these patients, they are poorly compliant, and if there is slight resolution also, they stop applying the topical treatment, and then it goes on and on. Inadequate instructions, then these topical retinoids and benzoyl peroxide, they cause a lot of dryness of skin, which in turn can be the reason that they do not use these creams and stop therapy. Resistance to P-acne can develop. Inadequate dosage of medication. Sometimes folliculitis due to staphylococci or gram-negative enterobacteria or malassezia can resemble acne, so that has to be excluded. Thank you. We can, if there are any questions, we can take them now.
So, madam, there are various questions appeared in the chat box. The first question from Apasya Patankar side is kindly guide on the supportive treatment like the cleansers, soaps, and sunscreen. Acne.
So, sunscreens are not a must, but moisturizers are helpful in the management of acne because, like I said, retinoic acid and benzoyl peroxide and even the topical antimicrobial, because they have a seborrheic action, they dry the skin, and that results in poor compliance of the patients. Hence, moisturizers have to be added. When we are choosing these moisturizers, we don't have to use the highly greasy compounds which have paraffin, because they per se can aggravate the acne. But non-comedogenic moisturizers like hyaluronic acid can be used. Sunscreens are not a must. Again, it will add to the cost of your prescription and will not add much to the value.
And a supplement question to that if what is the role of salicylic acid and alpha hydroxy, beta hydroxy facial washes, and how they has to be used ideally? Whether it has to be leave on for 5 minutes on the face, or we should wash it immediately after applying it?
Salicylic acid again has a seborrheic action. So, it will help in reducing the sebum content. Apart from that, there is not much that we are going to achieve. Again, in children, most of them have very sensitive skin. So, using a lot of compounds is not advisable. Salicylic acid can be used in the form of face washes. And yes, when they are to be applied, you can ask the patient to leave the face wash on the skin for 2 minutes or lesser than that if it's tolerating it. So that there is enhancement of the seborrheic action. But apart from that, other face washes can aggravate the acne. Hence, giving a salicylic acid face wash is an add-on thing to your prescription. But again, these are not primary.
Okay, there's another question, ma'am. Should we use combination of antimicrobial, retinoids, and benzoyl peroxide?
Yes, yes. Antimicrobial agents should always be used in combination with a retinoid or with benzoyl peroxide. They don't have to be used alone ever.
What is the role of diet in acne?
If the patient is looking obese to you, now what happens in these obese patients, there is a lot of conversion of the hormones in the fat. So if the patient is obese, you have to advise the patient to lose weight. If their diet is of a very high glycemic index with high unsaturated fat, that has to be reduced. But as such, there is no other restriction which is advisable apart from this?
What is the standard prescription to a 14-year female with a grade 2 acne?
14-year-old female with grade 2 acne. So you can give a combination of clindamycin and retinoic acid in the night time and ask her to use moisturizers in the daytime. And follow up after, don't see the patient again very soon, minimum 3 weeks before your next follow-up for the action to be seen. And if you want to add benzoyl peroxide to it, you can add on the next follow-up. But first time, giving clindamycin with a topical retinoid should suffice with grade 2 acne.
Madam, can azelaic acid can be used in pregnant patients?
Acetalic acid is pregnancy category B. It can be used, but when it comes to acne, acetalic acid is not a very good anti-acne measure. Okay, obviously in pregnancy you can't use topical retinoids. Benzoyl peroxide is always better. Acetalic acid is indicated when the patient is having any pigmentation after the acne is subsided. Patients who are having hyperpigmentation and darkening of the acne lesions, there you should choose acetalic acid. Otherwise, acetalic acid should not be used regularly for acne. It is not a very good compound for acne.
Yeah. Are there any more questions regarding
Yes. Role of vitamin C, vitamin E, and aloe vera, particularly in type 1, type 2.
Vitamin E has no role. Vitamin C also in children, it is not to be given. It can cause Commodore Lesions and it can cause more acne. So these serums are not to be given in children. Vitamin C in adults is used because it has a sun protective action more than anything else. But for acne, vitamin C serum is not in the treatment only.
What about aloe vera? We are seeing
Aloe vera can be used because of its soothing effect, but nothing more than that.
To avoid the picking temptation, the patches are available to be applied on the nodules. Are they advisable to be used in those who are having the nodular cystic acne?
So they are not used for preventing picking. If the patient is having a big nodule, these patches, they are small needle-like things and salicylic acid is there on it. So it can be tried, but we have used it and the results are not great.
Okay. Are there any more questions? I think there are no more questions. Thank you so much for your answering all the queries. And if there are any more questions, please free to ask them, and we'll afterwards also we can be in touch with Madam. Now head on to the session number 2 by Dr. Chandani Kharath, ma'am.
So hello everyone, and I'm Dr. Chandani Kharath. So foremost, it is really an honor and a privilege to be here on the platform of IAP Raigad. And let me take a moment and especially thank Dr. Vikas More sir for this privilege. And I'm really glad and excited to actually talk about a topic very, very close to my heart, and that is PCOS. And more so ever, we are actually going to focus more regarding the skin concern it comes along with and how to manage them. And so without any further ado, I start my presentation. I also bring you greetings from Medrika, which is the first cosmetic gynecology center of Navi Mumbai. And yes, so actually today as we're talking about PCOS in adolescents. And the thing is, primarily, I understand that we all are physicians and we all have an idea, a brief about as to what exactly PCOS is. So I'm actually going to, brush through, just give you an overview and concentrate more on the skin concerns. So foremost, let me tell you that there is a lot of controversy. There is still a query whether PCOD and PCOS are two different things or they are the same things. So can you hear me?
Yes, ma'am.
Okay,
Yes,
okay,
ma'am.
okay,
ma'am.
yes. So PCOD stands for polycystic ovarian disease, and PCOS stand for polycystic ovarian syndrome. Well, it is very much the same thing, but we no longer call it as PCOD, we call it as PCOS, because it's not a disease, rather it's a syndrome. It encompasses a lot of things, a metabolic syndrome, and gradually as we run through the slide, you will get an overview as to exactly what all it affects. So as it's written, polycystic ovarian syndrome, it is also known as Stein-Leventhal syndrome, is a common hyperandrogenic multi-system metabolic disorder in women of the childbearing age group, and major impact on the quality of life as well as fertility. And if you see, there is a criteria which we follow, which is known as the Rotterdam Criteria. Now, we always agree to disagree, and there has been a lot of controversy, a lot of discussion. We have revised over the criteria when to consider, a patient, when a young patient, an adolescent girl walks into your clinic, whether to label her at PCOS and what is the criteria. So finally, in 2013, we follow presently, we follow the ASHR criteria, that is the European Society for Human Reproduction and Embryology. And it states that, and it encompasses the Rotterdam criteria. So what is this exactly? Now, it should have 2 out of the following 3 criteria. One is oligo-ovulation, which means fewer than 8 menses per 12-month period, that is in a year, or an ovulation. Also, the second one is hyperandrogenism, which can be either clinical or biochemical. And I will throw some more light on it as we move on further. The next one is the sonographic criteria, which is polycystic ovaries, which means either the ovarian volume is more than 10 ml or they are more than 12 follicles, and the measurement ranges from 2 to 9 mm in diameter. So basically, these are 3. And if 2 are present out of these 3 is when we label as PCOS. Now, I would like to take a moment and throw some light that because, today we are dealing on a platform where, there are a lot of specialists who are catering to child health care, great pediatricians on this platform. So what happens, you are the first point of contact when a lady will get over her adult, her girl to you when she starts with her menarche. And, probably then they'll come over to us or either you. So the thing is, when will you start investigating a girl? That is very, very important for all of us to know. So understand the first 2 to 3 years, you do not label, nor do we investigate a case of irregular menses, provided there is nothing major or nothing hampering her life, her lifestyle rather. So if she is just having complaints that, that there's usually a history that her menses were fine, suddenly they're irregular, again, they were fine, there is fluctuation. So always give her a period of 2 to 3 years before we start investigating and concluding exactly as to exactly what it is. So moving further, as it's written here, PCOS in adolescents, the concern in adolescent with PCOS are twofold. The first involves the cyclic control of irregular menstruation cycle. This is the very, very first concern the mother will get the girl to you, and secondary, because there's so many other sequelae which it flows through are, probably she has put on weight, she is obese, she is having, gradually she's having some features of hyperandrogenism, which is a male part in hair growth, or she's having some velvety patches. Of course, this is just a glimpse and we will throw light on it later. And as I told you that, PCOS in a teenager is characterized by irregular menstruation. And when, as we told, it is less than 4 to 6 cycles in a year. And frankly speaking, the prevalence in adolescence has not been specifically studied, okay? But a very, very sad and a sorry state today is it is the new epidemic, believe me or not. The kind of people stepping in with PCOS, even after diagnosis, when we conclude, yes, this is a case of PCOS, the figures are really alarming. And it won't be wrong to blame the lifestyle, yes, purely, because the question arises that, so many years down the lane, even our grandmothers, our mothers, they never suffered. Then why is there a surge? So yes, lifestyle plays a very, very important role, and we will let you know how. So symptoms. Now, this is a flow chart which I wanted to put right in the beginning, because the main two culprit, or there is so much, it is end of the day, it is all about hormones. But the main two issues which causes everything, all the cosmetic concerns and hampering everything, right from putting on weight to, that cystic follicles in your ovaries, to the male pattern, even baldness and everything. There are two main pathological things. One is hyperinsulinemia and one is hyperandrogenemia. These are two things which we really, really need to just put it right and straight. So, and these are just, I've elaborated here that when we say hyperandrogenism, just 1 minute, yes. So as I told you, that is frontoparietal baldness, top and sides of the head. There is acne. Acne has been elaborated so beautifully by the former speaker. You also have, can you please mute your microphone? There is someone with an on mic. I think it is Dr. Jagdish. Can I continue?
Yeah, continue.
Okay. So there is blackheads, there is hirsutism. These are all features of excess of androgens in the body. Now, this is a gross clinical presentation, as to when we say or talk about PCOS, where all it affects. We know if you start right from the right-hand side, the topmost, it's menstrual abnormalities, which is the foremost symptom. Then is the hirsutism, the acne. Okay, the ecrodons is the skin tags. Okay, then acanthosis nigrans, obesity, alopecia. Alopecia is, shedding of hair. The polycystic ovaries, which we see on USG, that is sonography. Now, pathophysiology is multifactorial. I am going a little fast with the slides because I am just giving an overview, because it's important when we deal with skin concerns to know what is the basic pathophysiology beneath, or what is the culprit. So as I told you, just remember as hyperandrogens and hyperinsulinemia. So as it's rightly written over here, it's neuroendocrine disorder. There is defect in insulin synthesis. There is defect in beta cell function, defect in androgen synthesis. It is an inherited genetic disorder, which you will find flowing in families. If the patient is having, probably if you probe into history, the sister, mother, or even the aunts would probably having it. High variable phenotype, such as contribution from other factors, environmental, diet, exercise. Believe me, diet, exercise, environment, in fact, plays a major role in this. And also the peripubertal stress. That age group is something that, adolescent girls, boys, everyone. Now we are, of course, talking about the girl population, but they are juggling with so many things. So yes, stress is definitely a factor which we shouldn't ignore. Then is how do we assess them? The hormonal assessment. So this is just a go through of always, go for rule out if there is any hypothyroidism, check levels of this prolactin. Okay, also, later on in cases, we also try to rule out cases of classical congenital adrenal hyperplasia, check for serum levels of FH and LHs. As it's written, it's not mandatory. We kind to tailor make the treatment as well as only advise the necessary investigations. Now, AMH levels, it shouldn't be done as an alternative. Because initially, a few years down the lane, say 3-4 years back, there was a trend. We used to do AMH to find out how many follicles are there, to assess a fertility, but it is no longer a criteria now. And this is a flow chart of the test which we flow through, as I told you, thyroid, prolactin, your diabetes, because there is insulin, hyperinsulinemia, insulin resistant, leading to insulin resistant, there will be fluctuation in blood sugar levels. And then, of course, the hormonal profile, also check with her lipids and sonography. This is again a little more detailed chart, which I've jotted down. Okay, so here I just want to tell you that, the main sonography features, what you pick up is the ovarian volume, which is more than 10 ml. There are 12 or more follicles, as I mentioned earlier, also 2 to 9 mm in diameter. And of course, this is, a little more detail as to what parameters we look for when we do a USG. Now, screening of an adolescent with PCOS. Now, this is really very, very important because the earlier you pick, it causes long-term sequelae. It is a metabolic disorder. And if you just go through, it in the long run affects your cardiovascular system. You can drop into hypertension and obesity, of course. Lipid profile gets deranged, diabetes, as we told, because of the weight and other issues, they may also land into obstructive sleep apnea. Most important factor, we actually need to throw a lot of light and attention and give time to our patient for counseling, is for the psychological depression that PCOS comes along with. More so ever, because at the age where it hits on, that age, it is a very fragile age, and with acne on your face, or having a male pattern distribution of hair on your face, or having a kind of a prominent mustache, so that takes a psychological toll. Now, these are differential diagnosis, because when I told you we do a few series of investigation as and when required. So what are we trying to rule out? So that's the reason this has been put up. So what's the treatment? Of course, there should be a holistic approach. Give ample time to your patient, to share with you. There are kids who come over and they are so petrified because they really don't know what is going wrong with them. But when you give them time, it is your first consultation where you can actually hold up to your patient, give her the confidence that yes, you are there for them, and they can actually disclose all the problems, whatever is bothering them or concerning them. Then comes the main concern. Mothers are worried that period should be coming on time, whether she will menstruate every month. Okay, this how long the treatment will be on. There are questions like this. Okay, now the thing is, if you read on to the third line, reducing far-reaching consequences of insulin resistance and glucose intolerance, motivate and assist weight loss. The last line should be in inverted commas, actually, that is lifestyle modification is the first line of management and should be recommended to all those with PCOS. And this is just a little thing which we can suggest a patient as to, please do not diet. Dieting is not a solution. In fact, it will bounce back and rearrange your hormones. It's a big no. So never skip breakfast or your meals. It's important to have 3 meals. Where you need to cut down on your carbohydrates, and also on the proportion. You don't have to skip anything, but the quantity can be reduced, but that too gradually. And this is a little more detailed one when we take for gynecologists, that exactly how can you give them along. I share this chart with my patients as well. And, and you should always, give them something which is very practical. If you tell them that you have to stop this completely, it will not work. So this is just a pictorial thing. As it say, a picture speaks more than 1,000 words. So this is what veggies, fruits, and of course pulses is what you need to include. You need to cut down the junk food. I have seen this in my practice of so many years, that please do not tell your patients stop the junk food. That word stop gives a very, very negative impact. They will follow your advice just for 4 to 5 days, and then they will say, no, I cannot do. Rather, just give them a briefing period. Tell them, you can have a cheat meal once a week, no problem. You want to have burger, you want to have fries once a week. And then you should say, but probably it's not good for your health. So if you can just reduce it a bit. So that's how you have to counsel them. The main idea, the easiest way, a PCOS diet, we actually have a diet chart especially for PCOS patient. And the simplest way to tell them is, see, the more colorful your diet is, it's the most apt diet for you. Let it have a color red, orange, green, and then you realize that that's the perfect diet. Moving further, as I told you, diet and exercise. And okay, so exercise, when I counsel my patient, and I'm very, very glad. In fact, I had so many patients, I was happy. I tell them, just give half an hour to yourself. Half an hour is not a big deal. And you can also have once, you can break in for a day in a week, any day. And that 30 minutes should be dedicated to any form of exercise which you enjoy or which you love. It could be dancing, it could be Pilates, it could be Zumba, it could be gymming. And the best I say, even if you don't want to, indulge into something very aggressive, just brisk walking, normal, little just speeden it up. Just don't be very lazy when you walk. But 30 minutes, dedicated 30 minutes every day works wonder. Believe me, without doing anything else. I have patients reducing 1 kg weight in a week's time, and she has just cut on her sugars and beverages, the aerated drinks, a bit of carbohydrates, and she actually exercised all through with 1 day break. So it really works. And with only 5% decrease in your basal weight, if you're just 5%, you can and you investigate them further, or you can see, their periods have started kind of coming on time, the hormonal profile is getting better. So it really works wonder. These are some other things. These are charts which we share with our patient as to, taking the stairs or walking greater distance gradually, walking during lunchtime, walking over to meet a colleague. These are just some counseling things which you can, of course, share with them. And this is the chart which you can show that, don't be a couch potato and indulge into binge eating. Rather jog your way out. You can go for cycling. Somebody enjoys swimming. You can do that. It is very, very important that the treatment which we give, the medicines, but if we counsel, give them ample time, we give them some practical tips, it really works and it has shown results. So menstrual irregularity, very, very common. As I told, that PCOS is the new epidemic, it's just increasing and increasing and increasing. This is the commonest symptom which females present in with. So pharmacotherapy is the mainstay. The first line of treatment is COC, that is combined oral contraceptive pills. And I will just flow through this. This is the hormones which we prescribe. It is all tailor-made. We always start with a low dose, say with estrogen of 35 microgram and levonorgestrel or some other progesterone, depending on what she requires. In someone who is having a lot of androgen features, then of course we combine the OC pills with an anti-androgens, like something like cyproterone acetate. And depending on the requirement, we start with a dose of 2 mg. And as I told you, estrogen, we don't try to move further than 35 microgram, which is a low dose. And for insulin sensitizers, metformin is working wonders in case of PCOS. Inosol is a new introduction. We have been using it since few years now, and yes, it has shown a lot of improvement. Now, this is actually our main highlight for today. That is the cosmetic concerns of PCOS. I have brushing through the previous slide because we need to understand what exactly PCOS caters to. Now, coming to the cosmetic concern, which actually takes a lot of toll on adolescent. So if you actually see this flow chart, hirsutism, acne, acanthosis nigrans, then you see folliculitis, stria, that are those stretch marks. Then there is alopecia, there is acrochondrons, that is skin tags, that is warts, that is seborrhea. This is not necessary everything will be present in a patient, but yes, different patient has different profile. And this is what, PCOS cutaneous picture looks like. Now, the main mainstay is lifestyle modification. For a lot of people, when we say lifestyle modification, they feel, okay, but what else? Believe me, it is the mainstay, and that's the reason the chart has been put right before we step on to other treatments. And if you run through, of course, the hormonal correction remains the mainstay of the treatment. As I told you, the OC pills, the combined OC pills are the first line of treatment. Dietary recommendations, exercise, okay, monitoring that by the waist hip ratio, BMI, these are the parameters which we use to assess them. Now, this is acne. Of course, I'm not going to go in details of acne because, there has been a lot of enlightenment regarding acne. But in cases of PCOS, the reason I put on this picture is what we see is inflammatory acne. It is a red, angry looking acne. And most commonly, what I've seen in my patients, and you actually see it in cases of PCOS, is this portion, the jawline, covering the jawline. It looks like really fearlessly red. Acne treatment, I'm not going into this. We all know by this time. It has been discussed by the previous speaker. And there's a few more pictures that, how actually, if you just see the look, how painful it looks. There are a few histories, premenstrually they flare up because of hormones. Hormones responsible are the progesterone and the androgens. And the lower third of the face, as I told you, this jawline is the one which is really affected. Even on the neck, we see it following through. The arms, upper back, they are affected as well. So management, I'll skip through. We have Q-switch lasers as well. We have it at our center, and how we use it, we will just throw some light on it. Planning treatment is very, very important. Whenever you are planning, now we'll see what all options are there, but always discuss everything with your patient. Let your patient know in and out. There will be few queries which patient will probably not ask, but as a doctor, it's your moral responsibility to explain them every bit of the procedure. Does it have any complication? How much time will it take? What results? The important thing is what results are they are going to land up end of one session, because it's not a magical wand. Every session, after every session, skin takes time to repair. It's a tear and wear process. So that it should be very, very crystal clear. And so yes, now if you see, look closer, have a closer look at this picture. This is male pattern of secondary or post-pubertal hair. It is thick, it is long, it is dark. And of course, the physiological hirsutism should be ruled out. Role of androgens. Now, important is also the sites which are involved. As I told you, the face, the sternum, they also have around their breast area, upper back, inner thighs, also at the lower abdomen, the belly area. This is a scale which we follow, and we accordingly, you can score it up. So this is very, very, when we actually jot it down, this is a very, very important chart as to, then we label it as to it's normal, mild, moderate, or severe. It's a visual scale. Management, of course, you have a lot of, other than the hormonal thing, when there is hair, imagine there is hair on a young girl's face. So what she will opt for, somebody says wax it up, shave it up, or epilate it. Of course, we have efflothione, hydrochloride creams we have. But now the mainstay which has come, the innovative thing is the laser hair reduction. And it is really, really very effective. And, there are, depending on your hair and skin type, we schedule sessions for you. We have the best one is the diode hair, laser hair reduction. And on this note, I will just tell you that never call it, it is not laser hair removal. No, it is laser hair reduction, which means the growth will gradually reduce. It is different in every patient, I had one of my close relatives, in fact, my first aunt, who did so many years back, and she never had to go for any follow-up session. It was that clean. Now, in few cases, you will find that's the scenario. In few cases, you will find that, depending on their growth and the type, the hair type, their number of trips to parlor or number of times they shave or bleach has comparatively gradually reduced. And and with all follow-up sessions, it reduces further on. So all this needs to be explained to the patient. And yes, so evaluation, counseling, and how it works. The main chromophobe which this laser targets is the melanin. And as I told you, there are multiple sections. Of course, say anywhere from 6 to 8 or even up to 12 sessions are also required. Maintenance session, we always tell patient that, you will be needing once in a year or twice in a year. But as I told you, there are so many clients of mine who never, they had to come over for follow-up. They were that clean and happy. Of course, our first series of session, you have to complete the first 8, first 10 or first 12, and then follow up. And then you may or you may not require. So, but always, even you're very sure in this case, 100% you're sure there will be almost like a complete reduction, but do not say that. Say it will be 70 to 80%. Photography is very, very important when, particularly when you're dealing in this domain of cosmetology. You have to jot down everything, and you have to also have a visual, a visual proof that how the treatment has improved over the course of time. And then this is actually flow chart of how things are done, how we shave and anesthesia, and we use the handpiece. So this we can actually skip over, and here I can show you that, the hyperkeratosis of skin, how are the velvety dark patches on the skin folds. This is how it is seen. You can see it at the nape of the neck, very, very common. Axilla, the next common place. Even the vulva, yes, we have seen in vulva in so many cases. Periorbital, perioral, dorsum of your hand, feet, elbow, antecubital fossa, knee. Okay, and how do you manage? If you actually see very carefully in all the charts, the lifestyle management plays a very, very important role, because it really, really does. Then is, of course, investigating, finding which hormone is the culprit. We have a lot of tropical things. And your, for hyperpigmentation, Q-switch anti-acne laser, they really, really work well. I have used in my patients. We have it at our center, and giving very good results. Now, this is the dihydrotestosterone, the main offender, causing the female pattern baldness, it kind of resembles the male one. And there's so many treatments available. My personal favorite these days is the PRP treatment. Of course, it's beyond the scope of today's discussion, but maybe later on at the end, we can throw some light on what is PRP. And psychosocial management, very, very important. Equally important is parental counseling. It plays a very, very crucial and a critical role. And there is something known as body dysmorphic syndrome. Whenever you are keen in practicing cosmetology or even dermatology, this is one syndrome which you should be aware of, in which the female feels everything about her is not right. Probably she's not happy with the shape of her eyes, with her nose, with her breast, with her body. So these are these are patients, no matter however good treatment you offer them, however good, effective the results are, or up to the point, but they're not satisfied. They are actually juggling with a disorder called as body dysmorphic syndrome. And yes, so basically PCOS is more of a multidisciplinary approach, right from a gynecologist, a cosmetologist, a dermatologist, endocrinologist. Counseling plays a very, very important role. Or it's a teamwork, and what is visible might be more of a concern to patient and parents alike. Whatever the acne and everything, imagine having just a small papule or a boil, it really bothers. So imagine your whole face having a flared up papule, inflammatory acne, okay, or you having hair all over, or you having black patches which are visible. You are also juggling inside with irregular periods. So it really takes a toll on everything. Psychosocial impact must continually be assessed and managed. Well, this is a picture from our center wherein I'm showing the diode laser head reduction. And this is, we actually have, you must have heard of the latest Safrano ice cool technology, which means you don't feel the heat and the warm, you actually feel it cool. It's painless, very, very effective. The next one is radio frequency, not for today's discussion. Then we have HIFU, which we can discuss sometime later. Okay, this is a Q-switch laser, which you can use great for today's topic, great for removing the pigmentation, the hyperpigmentation. Otherwise, have a lot of applications from tattoo removal to melasma treatment and so on and so forth. And this is I'm just giving you a glimpse of our laser aesthetic room. We have dedicated a separate room because when it comes to a laser head reduction, I think shaving and everything, secluded is best. And so this is one, and this is a glimpse of our cosmetic gynecology procedure room. This is PRP. This is what I wanted to show. We have a PRP centrifuge machine as well. And this is one of from a patient which we did recently, and I snapped in a photo. So we actually call it yellow gold. And PRP is a topic in itself, but fantastic, something really, really fantastic. This is actually, I'm doing the treatment called as microneedling with PRP. We also do it in cases of acne as well, gives fantastic results. And yes, I bring you greetings from my center, and also take the opportunity to wish everyone out here a very, very happy Women's Day, and also the men for always being on our back and supporting us. So yes, thank you. Yeah.
Yeah. Thank you so much, ma'am. That was such a, I think there were almost 63 slides. You covered it, you covered it in quite detail.
Yeah, I wanted to be on time.
Yeah, that's very good. So I have a confession that a few days back, referred a patient to ma'am of melasma, and I
Correct.
thought it is a completely lost case and there is no cure at all. But the kind of result I was really I was surprised. So there are many things even I don't know that many things are happening in cosmetology. I personally feel that the madam has emphasized again and again that lifestyle modification, exercise, and the hormonal therapy is the basis of the foundation of the whole treatment, and cosmetology is on the top. So unless and until you take care of all those, you can't get a success, even with any kind of laser. So if any more questions from any attendee.
And I also want to just add on one point is that, you know, the first question, what moms will ask you, and even the girl for that matter, that, you know, so I'll be cured up completely. So any gynecologist, any doctor telling you that PCOS is 100% curable, it is wrong. You know, it is false, you know, what we are putting across to the patient. Yes, it is 100% manageable. You can manage with your lifestyle modification, with your exercise, with your diet, hormonal control and everything. Yes, 100% manageable, 100% curable. No, not at all. And the beauty is when we talk about like cosmetic gynecology, what we realize is, you know, we were taking care of the hormonal assays, and the dermat used to take care of the skin concerns. But somewhere there was a gap. So, you know, when you have it under a roof, taking care of your hormones as well as your concerns, because, you know, as I mentioned regarding the laser hair reduction, see, if I'm doing it superficially, but I'm not controlling the hormones, it is not going to give me the results which I expect. It is going to bounce back, you know, it is not going to be effective. It is very, very important to have a good control of hormones hand in hand with the add-on therapy of laser hair reduction, which is really fantastic. And the most important, other than lifestyle modification, exercise, counseling is something we actually need to give ample time to the patient. And they are so receptive in that age. You know, they really, you know, if they are happy and they feel that, yes, they can confine in you, they really listen to you. And that itself makes your treatment worthy.
Thank you so much, ma'am. Now, in the times of social media, everyone wants to look beautiful, and even adolescents have the right to look beautiful. Sometimes their parents are not aware of their desires, or that they also want to look beautiful. They want to impress upon the people. So we need to understand the emotional needs of the children these days, and if we ignore them, it will definitely hamper their psychological health. So thank you so much for both speakers for their excellent presentation. This is absolutely new field for pediatricians, and our IP Raigad actually desired to have this touch upon on this topic, and from Akanksha ma'am and Chandni ma'am, you have done a fantastic job today. I now request Dr. Dhananjay, our dynamic secretary, to give a Thanksgiving.
Thank you very much, sir. Today is International Women's Day, and it was very apt to have two of the renowned lady speakers for today's session. On behalf of IIP Raigad, I would like to thank Dr. Akanksha madam and Dr. Chandni madam for their wonderful presentation. We all must have attended many dermatology CMEs earlier. Today's topics were a bit unusual, uncommon, but both the speakers presented so crisply and in depth. I'm sure we will benefit. We will be getting beneficial in our day-to-day practice. I thank again both the speakers. Thank you, ma'am. I also thank Dr. Vikas More sir for his for organizing this CME, and as well as for wonderful moderation. I thank Dr. Sanjeevani madam for introduction. I thank Dr. Pramod Wankhede sir, our president of IIP Raigad. Sincere thanks to Dr. Hemant Gangulia sir, MahaIP president. Also sincere thanks to Dr. Dabhadkar sir, Dr. Sasade sir, Dr. Aparna Sathe madam, Dr. Abbasaheb Patankar sir for his valuable inputs. Sincere thanks to Dr. Nilima Bhandarkar madam and all the dignitaries of IIP Raigad members. And finally, sincere thanks to Dr. Vishal Raut sir for making this session on our Zoom platform available. Thank you very much.